Hi, this is Reed Jacobs. I'm the Social Worker and Bereavement Services Coordinator at Faith and Hope Hospice. This is a COVID conversation, and today we're talking about COVID's impact on grief. And Kathie, could you introduce yourself and tell us a little about your work?
Yes, hi Reed, and thank you everybody. My name is Kathie Supiano, and I'm a palliative care social worker and a hospice social worker and a geriatric social worker. And I'm on the faculty at the University of Utah. I'm really happy to be here with you today.
Well, thank you so much. I appreciate it. And I know I've worked with you before in some committee work, and I really respect your opinion and have enjoyed working with you.
Thank you.
Yes. The first question I had for you is, in general, how do you see COVID-19 impacting bereavement and people's grief experience?
Well, Reed, I think it affects grief before the death actually happens. And so one of the big concerns is family members not being able to be present at the time of death. And in home hospice, those rules are softer, but a lot of hospice care is delivered in nursing homes. And nursing homes are being and assisted living facilities are being devastated by COVID. And it's where the majority of the deaths are happening that are happening in older adults. And many times, and there's some softening of these rules in the just last few days in some locations, but families are usually isolated. They're not able to come in and be present during the dying, during the death, immediately after the death. And I think we've underestimated how important that time is for families, certainly not social workers or chaplains. We really care about that. But boy, it's a lot more than symptom management to give people a comfortable death. And for many people, a comfortable death is the presence of the people who love you. And for people who are moving into their grief journey, being present at the time of death is very significant for many of them. And we are grateful for Zoom here. We're on Zoom today, but Zoom is nothing like touching someone or holding someone or putting a cold washcloth on someone's head and feeling that that interaction. So I think that's the first thing. And then secondly, the bodies of the decedents are swept away rather quickly. They're taken to the nursing home. At least where I live, many times in our Hispanic communities and in our LDS communities, care of the body is part of their practices afterwards, and those things are not allowed, even in cases where there's no COVID involved.
Wow.
And so this is quite a variance for people. Many people are opting for cremation. And of course, cremation is not necessary because of COVID, but many people are opting for that because there's no large scale viewing. And so that has changed practices. And of course, the funeral experiences are just profoundly different. If you have a funeral of 8 people who are, positioned across the room broadly, rather than arm in arm and hugging and crying together. So all of these things, this is really uncharted territory in grief.
Yeah. I know when I'm working with people whose loved one is dying, especially in the last few days of life, and they don't know what to say. They don't know if their family member can hear them. If they do say something, one of the things I talk about is the power of presence and just being there and just holding someone's hand. And now that's being taken away.
Right. And that's on both sides. So of course, not as warm a dying experience for the patient, but certainly, many of us can look back on some of those dying moments in many of our clinical experiences, and for a lot of us in our personal experiences, and we view that as transformative and sort of the moment that grief starts. And when the moment of grief starts in this much more unsatisfying way, it can be hard. Though I do have to commend nurses and hospice providers and nursing home personnel who are really trying to be creative to come up with ways to create presence when there isn't presence. And just yesterday saw this picture of a nurse in a nursing home who held up a sign to the family outside because the glass had to be closed and the window, and said, "She wants you to know she loves you."
Mm.
And those moments are touching, but they don't approximate the real experience.
Yeah. Yeah, I have a friend whose father is in a skilled nursing facility, and thankfully it's one that's well staffed, and they're able to have video chat conversations every day. One of the nurses there in particular is kind of taken to her dad and kind of facilitating those conversations. So I'm glad to hear that for her. I know that's not something that's happening for everyone, but
Right.
there are a lot of stories about people finding creative ways to still engage.
Right. And this is an advantage of social media because these ideas are moving across the country
Mhm.
rapidly. I mean, we're learning best practices in real time.
Yeah, yeah, especially as things change on pretty much a daily basis. And yeah, like you were saying, social media, all that information can travel around the world very quickly.
Right. For better or worse.
Right. Um, and I wanted to ask you about complicated grief.
Mhm.
Um, at first, if you could tell us a little bit about what complicated grief is, and does COVID-19 put people at a higher risk for developing complicated grief?
Thank you. So complicated grief, and we expect complicated grief, which will be called, most likely be called prolonged grief disorder, will be now a diagnosable condition in the modified DSM-5. So there is an affirmation that there is a problematic and disabling form of grief. And I always like to start that by reminding people that grief is normal, it's healthy, it's part of the human experience, it's actually a sacred part of the human experience. But for between 5 and even 20% of the population, depending on other circumstances, as well as the situation of the death, um, people can be at risk for a disabling form of grief, which I will refer to as complicated grief. And these are situations where the person is not able, because of the grief, to function socially or occupationally. They withdraw from people that they formerly trusted. They live lives of unrelenting sorrow and yearning. And basically, their life stops when the person who died's life stops. The newer criteria that we expect to be endorsed indicate that we don't diagnose this until 12 months after the
Hmm.
death. I find that concerning. It was 6 months after the death before. I struggle to think about people not getting sufficient care or treatment in a year,
Mm-hmm.
because we are pretty comfortable knowing what the risk factors are for
Okay.
complicated grief. So to that point, the experience of COVID, there are many, many things that would kind of tee people up for a complicated grief experience above and beyond the known risk factors.
Hmm.
So first of all, we know that ambiguous loss, a loss where there's uncertainty about causation and circumstances of the death, the disposition and of the body, all of those things. Ambiguous death, which is a concept developed by Pauline Boss, that places people at risk for complicated grief. And we see that kind of grief when there's a suicide death or a overdose death or a situation where the body is not recovered. But when a person is uncertain about the circumstances of the death, and of course, with older adults dying in nursing homes, death is multifactorial. And typically, but when people are present at the death and a hospice team can say, this is what's going on, and this is why she looks this way, this is why the skin is blue, this is why the breathing changes, what we're doing is giving people certainty. And that's very protective against complicated grief.
Hmm.
The other thing that's going on is disenfranchised grief. And this, as a geriatric social worker, is just ethically terrifying for me. We are seeing the lives of older adults, and particularly older adults living in care facilities, really devalued in our society now. We're hearing a lot of old people should die for the benefit of the economy, and language like that that's profoundly ageist and disparaging. And so we're seeing more of a phenomena that already existed when older people say a person with dementia dies, and people say, oh, you should be so relieved your dad is out of his suffering. And of course, we are relieved when people are out of their suffering, but it devalues that life. And so disenfranchised grief is also something that we may see more of with COVID. Also, societally, we know that there are governmental powers that don't want an accurate death count, that we see in Florida, where the state government has forbidden county coroners from releasing COVID death data. So all of this is creating this blanket of uncertainty and shame around these deaths. And then you have a funeral where people aren't allowed to participate, and the griever is now denied the natural forms of support that they would have had. And I don't want to minimize this, but we think about people bringing casseroles to the house or sitting Shiva or those sorts of things. And I think we've underappreciated the funeral industry. These are services that start people on the pathway to grief that's supported and endorsed and acknowledged, and where people get the comforts of each other, where people hear memories and stories about the person who died. So if we strip away all those things and leave people in this position of ambiguous and disenfranchised grief, we are going to see a lot more complicated grief. The other thing is, I will tell you, these deaths of COVID, these are really awful deaths. And when people do witness this, they experience this as trauma. And so we will see this with staff as well as family members. And in our trauma-informed care, we know that when people didn't see the death, their mind creates the visual. If you don't have the visual, your mind will create the visual. And sometimes that visual that the mind creates is actually worse. Yeah. So we need individual care, we need family care, we need care in our communities. And I hope you don't mind, Reed, this would be when I would mention that one of the initiatives of the Social Work, Hospice, and Palliative Network is to call for a national strategy on addressing grief. And not just, I'm not minimizing it, not just the grief of a death by a death by a death, but our nation has experienced over 100,000 deaths. And, you know, this number will go up. We know it will go up. And we know that in the second wave of consequences of the impact on regular chronic diseases, either that got inattention during COVID or are now layered onto COVID. We know there'll be renal consequences. We know there'll be cardiac consequences. We know there'll be cognitive consequences on survivors. Yeah. We are really going to see a domino cascade of death. And when we do, you know, the grief comes after. So we do need a strategy. And I think hospice professionals, whether they're caring for COVID patients directly or indirectly, hospice professionals are the ones who have the skill set to address this collective suffering as well as the individual suffering.
Yeah, hospice can play an important role for that. Right. And I like the idea of a national.
Many hospices that offer grief support groups open their programs to people who didn't even die in that hospice. And I've always felt that that was a gracious mercy that the hospice agency provides to their community of service.
Yeah, definitely. And I know we're currently looking to start a support group. It'll be online and specifically related to COVID, and not just for our patients, but for the community, because there's going to be so many people.
We are too, and in our program, the Caring Connections, the grief program I direct at the university, we have loss-specific groups: loss of spouse, loss of a baby, loss by suicide, loss by drug overdose. And again, I think we're recognizing that the COVID death will require sort of a individualized, tailored support support group model.
So we've talked about the risks for complicated grief and how COVID is increasing those. How can risk factors be mitigated?
Okay. So I think the most important thing is, and again, we're so dedicated to moving palliative care up the disease trajectory. And so we similarly need to bring grief attention in a preparedness model. And so, the idea of anticipatory grief is still pretty controversial. Is it something separate? Is it really grief that starts beforehand? That's sort of splitting hairs, but we know we can prepare people. One of the challenges with COVID is people die these deaths in very varied ways. Not every death looks the same. And so, when you're caring for a person dying of end-stage renal disease, you can pretty comfortably tell them what's coming around the corner. With dementia, the timing may be difficult, but we can tell people what's coming around the corner. With COVID, there's a lot of uncertainty. And so that does challenge us with preparing people. But if we can't prepare people with facts, we can prepare people for uncertainty. We can do that. This is what resiliency building is. This is what these skills are about. And this is what the most important thing is, our commitment as end-of-life practitioners to commit to caring for people across the distance, we always say from diagnosis to death and beyond, right? And so we care about that. And so that relationship they form with a provider, with a social worker, with an IDT, if that can carry, that's really important. Many of the risk factors can't be mitigated. The historic relationship between the person who's dying and the person who's surviving, obviously we can't change the story, but we can help people interpret the story differently. We can always help people understand that you may not want to grow up to be like your father, but what can you learn from your father's life that will inform your life? And we can help people with meaning making. Now, meaning making, as you know, is Niemeyer's model, but and he has said, and many of us have said, that meaning making is sort of like one of the later achievements in grief. But a lot of our research is indicating that meaning making is a process that starts in the end stage of life, not just meaning making for the person who's dying, but meaning making for the family. And that can also be a dyadic or a family experience, and can be very profound. Again, COVID absence makes that challenging. Other risk factors that we can address are affirming that the caregiver did a good job along the way. And that is not just offering a platitude, but engaging in a dialogue and letting people say, gosh, I really wish I had, or these are my regrets. And just letting people process those regrets and surrender those regrets. If the sooner people can do that, the more comfortable they are forming that relationship with the person who died that they want to carry forward. So one of the things I always think about is my therapeutic goal with grief, whether it's normal grief or complicated grief, is that when we're in the throes of acute grief, all those memories are circulating in our head and in our mind, and I wish I would have, and my regrets, and I shoulda, woulda, coulda. And then as those are processed over time, the memory of the person, not a glorified memory, but the real memory of the person, is held here in your heart. And the circumstances of the death can be held at arm's length. Whether that's a suicide, or my child died by a drunk driver, or my mother died of COVID, we don't want the circumstances of the death to be the defining memory of the person who died. And so the beauty of hospice work is we let families give voice to all of that all along the road. And then when they get to that death, and then the aftermath of that death, then they're able to say, well, maybe my dad was a jerk, but I can see he did the best he could. And yes, I wish my dad would have apologized to me as he was dying, but at least I apologized to him. And so we can get to a place where people can say, sure wasn't perfect, and I benefit from a do-over, but given what we had, I'm content
Mm,
to accept
mm,
how things were. And most importantly, I can go on and my future life will be informed by that person's life, but not tethered to it. And
mm.
those are different things.
Yeah, that's a good distinction.
Yeah.
Guilt is very common in grief in general, and
Mhm.
it's going to be even more. And I'm already working with clients who are experiencing extreme guilt because they weren't able to be there with their loved one as they were dying. They had to be separated from them,
Right.
and yeah, with acknowledging that it was out of their control, that they didn't
Right.
really have a choice to be there.
The one side of it is accepting what you can't control, but embracing what you could control, right? So if you're the adult daughter and you say, well, I feel really guilty, I couldn't be there with my mother, but I did what I could. I secured the best hospice agency I could. I kept in close contact with them. I made sure my mother had access to an iPad. I called every day. I had the grandchildren write pictures. These are the things I did. And I think the other thing is we have to remember that this is not part of the hospice world, but in the broader world of death, most people aren't present at the time of death. The
Mm,
police come to the door and they say, we found your dad dead at work, or this car accident happened and your son died. So absence from death is something that we can normalize. It's not desirable, but we can actually normalize that. And
mhm.
even how many hospice stories do we have of the patient who died when the family went down to the cafeteria, right?
Yeah, yeah,
And so sometimes absence, I mean, we can't frame it as a mercy, but we can frame it as something that doesn't define ourself as a loving family member. And I really always encourage people to take the longer view, not the moment of the death. I mean, even when the moment of death is satisfying and the family says, oh, this is what mother would have wanted, and she was comfortable and we all got here, all those deaths that we all want, those rarely accomplished but meaningful deaths, even that shouldn't define your relationship with the
yeah,
person who died. It should be the whole balance. And I think helping people explore that whole relationship of the life lived together, for better or worse, I think that's a
mm,
powerful part of this. And complicated grief therapy, the key element of it is going through pleasant memories, going through difficult memories, and integrating memories into a reasonable recollection that's of the person who died.
yeah. Mm. I like that. That's
And the mind does that naturally over time if it's a normal grief process.
the last question we'll end on is um, what good can come from the changes that we're seeing um, around COVID, or can there be anything good come from a pandemic?
Well, I guess this is part of our social work values of finding the strength in all of these stories. We have in front of us, really, I think, a unparalleled opportunity to transform healthcare in the United States. This pandemic has laid bare the healthcare inequities in this United States, the disparity between poor and affluent, the clearly defined haves who have health insurance because of the kind of job that they have, that they just happen to work enough hours to qualify
Hmm.
for health care. These people now unemployed or without health care benefits, we're going to see enormous consequences. So there's an opportunity in every single crisis to bring about meaningful change. But I think just the issues in the last couple of days of seeing the racial tensions in the United States and the violence that's come is another disclosure of devastation on minority communities who are disproportionately affected by COVID, disproportionately affected by lack of access to healthcare, and then, of course, systemic and structural racism. So, I mean, we have the opportunity to be part of the story of change here. And I'm older than you, and I remember the civil rights movements of the late 60s and 70s, and it grieves me painfully that we are no farther than we are, but we aren't. And so we can be part of the solution here. This will take some of the skills that we do best. I mean, hospice and palliative care is about listening. It's about goals of care, and not our goals of care, the patient's goals of care, and what the family needs. And so we are about rights and autonomy, and we are about systems and system change. So I think the community of hospice and palliative care in general, and social workers in particular, chaplains, nurses, we all have our voice, we all have our own platforms. And now is the time to speak out, but also most importantly, to do what palliative and hospice care does best, which is listen. And that's really exciting. So it's terrifying, but it's an opportunity.
Thank you so much. I appreciate you taking the time and sharing your wisdom on this topic.
Okay, well, thank you for the opportunity, Reed. Bye now.